Hello dear friends, this is a case of a 73-year-old male who presented with abdominal pain, significant distension and absolute constipation. For the last 36 hours the patient did not pass any flatus and the abdomen was significantly tender. So CT scan was performed for further evaluation. What we see here as a general impression is that there are multiple dilated bowel loops with air fluid levels. The first question is the large or the small bowel dilated or both? This is the first question for the approaching. We usually start from the rectum, the anorectal region. The rectum is empty. That means that the obstruction is more centrally. So let's go and follow and track the large bowel. And here we see something. Let's scroll up the image again from the rectum. Here we are. Let's go up here. Just follow my arrow here. Okay, here is the sigmoid colon. Here, sigmoid, it is empty. Here, sigmoid colon. And suddenly we have a stop here. Just a moment to zoom in. So take the time and have a look. There is an abrupt stop, abrupt stenosis. And beyond that point there is dilatation. You see, all this is a dilated large bowel loop. Let's zoom out. Here is the loop again and goes up. Here is the descending colon, which is dilated with air fluid levels, continues here. And here, we must always search for a second lesion. Sometimes this happens, so we must make sure that there is no other lesion. Okay, here at this point there is the appendix. It is the appendix which is normal, where the arrow is. It's a good opportunity to see the appendix, a normal appendix here, 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 and its origin. All right. What else? At this point is the ileocecal valve, which is normal. Here is the terminal ileum. But anyway, due to the significant dilatation of the rest of the large bowel, the small bowel is also dilated and it shows some air fluid levels. As you can see, all this is a small bowel. In coronal views now, let's follow and track the large bowel from the anorectal region here. Let's track it up. Here it is collapsed. Here it is collapsed. collapsed, collapsed, and exactly here is the abrupt stop. Another point is that there is some pericolonic fat stranding. It is reactive. All this is reactive pericolonic fat stranding. In sagittal views, we can see the peripheral large bowel, the sigmoid colon, which is collapsed, goes here, and at this point there is the abrupt stop. It is clear again that there is pericolonic reactive fat stranding around this region, and here is the colonic tumor. Beyond this point there is dilation of the bowel. This is the dilated large bowel. Okay, here is the tumor, the dilated large bowel. And in the periphery, the bowel is collapsed. Another question, is it possible to see the tumor itself, the mural malignancy? The answer is yes. If we set the windows properly, we can see some parenchymal hyperenhancement in this region. It is a circumferential tumor. And there is significant mural thickening in this region and a degree of shouldering. This is probably a very small, minimally reactive lymph node adjacent to the lesion. There is no significant lymphadenopathy in this patient. Next point is to see if there are some metastases, particularly in the liver. There are few mildly hypoattenuating foci in the liver like this, but this is just a portal venous phase. It's very difficult to be characterized, particularly given the small size of the lesion. Probably this is a cyst, but further evaluation is recommended with ultrasound to be confirmed. I will scroll up and down around the colonic malignancy to have a second look again. Dear friends, thank you for watching and your support. Please subscribe to my channel, and I will see you later again. Thank you very much.